get started right on cue.
Sounds good.
All right. Well, I think we've given everybody the customary 1 minute. It's my pleasure this afternoon to introduce our Grand Round speaker, Dr. Irfaan Abid. Dr. Abid received his undergraduate degree in biology at the University of Wisconsin-Madison before heading east and receiving a master's degree in microbiology and immunology from Johns Hopkins. And then he took a real cross-country trip to Glendale, Arizona, and completed his medical training at the Arizona College of Osteopathic Medicine before coming back to the Midwest and completing an internal medicine residency training program at Hennepin County Medical Center. And then we were lucky enough to recruit him as a fellow, where he is one of our second-year fellows and will be completing training in June this year before starting practice in St. Paul, Minnesota. So moving back up north. And we're excited to hear your talk about the management of pituitary adenomas in pregnancy. All yours, Irfaan.
All right. Well, thank you for that introduction. Yeah, I will just dive right in. So the topic that I'm going to be going over is pituitary adenoma management in pregnancy. And I chose this starting off. I have no disclosures, but I chose this because just kind of looking through recent publications, there was a guideline published by the European Endocrine Society specifically for pituitary management in pregnancy, pituitary adenoma management in pregnancy. And I was looking to see if we had any such guidelines through our endocrine society here. And there isn't a concise or specific guideline towards pregnancy. And it's kind of scattered throughout the different guidelines that we have here. So I wanted to see one, since this is the most recent guideline that I could find, it was published in August of 2021, how that would compare to the guidelines that we have here, the various guidelines that we have here. So the objectives that I wanted to review the guidelines, compare them between the two or between the many different ones that there are. And then based on those guidelines, determine who would be a candidate for treatment during pregnancy based on the disease that they have and the characteristics of their diseases. So like I mentioned, so the European Journal of Endocrinology, they published their clinical practice guideline on functioning and non-functioning pituitary adenomas in pregnancy in August of 2021. The Endocrine Society here, their Journal of Clinical Endocrinology does not have a specific guideline tailored to this topic, but instead the recommendations are kind of scattered through each disease's guidelines. Just some very basic background information just to get started. for a pituitary, microadenomas are less than a centimeter, macroadenomas greater than a centimeter. Patients, female patients with adenomas, they often have difficulty conceiving, which may be due to hormonal excess from these adenomas. The pituitary gland naturally will increase in size during pregnancy, which is important, especially when you have a macroadenoma, and I'll get into that. And an important complication for these patients, rare but serious complication, is pituitary apoplexy, or hemorrhage into the pituitary gland, which can occur and is more likely to occur if there is a tumor present already. So for this talk, I'm basically going to be going through 4 different disease entities. The first one I'm going to start with is non-functioning adenomas, and then go over prolactinomas, acromegaly, and then Cushing's disease. And I'll start with going through what the guidelines recommend from the European Endocrine Society's article, and then compare that to what we have through the Endocrine Society here. So starting with non-functioning adenomas. So per this new guidelines, pre-pregnancy, they recommend that if there is compression of the optic chiasm or any visual field impairment, the patient should have surgery before they become pregnant. It's near the optic chiasm. They say that you can consider surgery, especially considering that with pregnancy, the pituitary gland may grow and then push on that optic chiasm, which obviously would be a problem. Also, you can consider surgery if there is a hormonal deficiency, as surgery can improve pituitary function and thereby improve fertility in about 30% of cases. Now, the evidence that they cite for this, it's not the greatest evidence. It's overall weak. I mean, there isn't a whole lot of data behind this, but there's a meta-analysis of a case series done. It was published in 2010, and based on that, about 30% of patients did have improvement in their pituitary function, but they didn't look specifically at would it improve fertility. That's kind of more so just a hypothesis. I mean, it's a likely hypothesis, but it's not, direct evidence to that. Now, one of the important things that I think is nice to have outlined in a guideline is that they state that if there is a non-functioning microadenoma and that the pregnancy is overall uneventful, that they don't need regular endocrine follow-up. And they base this, there was a study done a long time ago, back in 1994, where they had a total of 65 patients. 57 of them had microadenomas, and they followed them throughout pregnancy. And those 57 that had the microadenomas, none of them, including patients who had multiple pregnancies, had any visual disturbances throughout their pregnancies. So based on that, they determined that microadenomas are pretty low risk for having any significant complications during pregnancy, and that these patients probably don't need to be seen by an endocrinologist during their pregnancy regularly. This is something that probably would come up, more often than some of the other stuff that I'll go over, where a patient may see their OB and in the chart note that they have a microadenoma, and they rightfully would think that they need to be seen by endocrine before before we get too far into this. And it's nice to at least have this in a guideline stating, and at least have some evidence pointing towards the fact that they may not necessarily need that. Now, during pregnancy, if there is concern for tumor progression or apoplexy, that you should perform an MRI without contrast, plus get a neuro-ophthalmologic exam. I mean, this is a pretty straightforward, makes sense, but things you look for, any visual field impairment, severe headache, cranial nerve palsies. If you have any signs or symptoms of that, you can get an MRI and get an exam. If they have significant symptoms due to the tumor progression or mass effect on the optic chiasm or anywhere else, surgical decompression is recommended, and they recommend it in the second trimester. Why exactly the second trimester, it's a little unclear. I think it's more so third trimester it's the risk of anesthesia and all of that is too high. And first trimester, I think, is same sort of situation where the risk of complications for the fetus are probably too high. So the second trimester is where they recommend surgery if needed. Understandably, radiotherapy is not recommended during pregnancy. That is contraindicated, any radiation therapy. So those were the guidelines based from the European Endocrine Society. So for the Endocrine Society guidelines here, they have, looking through all of them, there's a guideline published in 2011 for pituitary incidentalomas. And in that, they have a very small section about what to do when patients are planning to become pregnant. And really all they say is that they suggest surgery for patients who have a lesion that's close to the optic chiasm and that they plan to become pregnant. And they suggest this based on the fact that there's a risk of lactotroph hyperplasia, and therefore you can have mass effect, visual field deficits, etc. during pregnancy. But that's really all it is. It's just one little section, and that's really all we have from this guideline. So the difference is obviously the European guideline, much more in depth. They give you a lot more to go by for pre-pregnancy and during pregnancy. And there really aren't any specific guidelines for management during pregnancy from the Endocrine Society here. So now, prolactinoma, probably a little bit more common thing that we may see. So for prolactinoma pre-pregnancy, the recommendation is that you treat with a dopamine agonist to normalize prolactin and ovulatory cycles. They recommend that you use cabergoline because it's better tolerated and has been shown to have higher efficacy in reduction of prolactin and tumor shrinkage. Looking into some of the data, so there's this paper published in 2010 where they used high-dose cabergoline therapy for patients who had prolactinomas, both micro and macro prolactinomas. And they used up to 5 milligrams per day, so it's pretty high dose cabergoline therapy. And in these patients, every single patient had shrinkage in their tumor. So looking at these graphs, tumor height, every single one, micro and macro adenomas, they shrank. Tumor volume, they all shrank. And then that last one with OP distance, that's the distance between the optic chiasm and the pituitary gland. So that grew, so there's more distance between, meaning that the tumor shrank. So every single patient had shrinkage of their tumor. It was a grand total of, I believe it was 75 patients or so, something like that. Then the patients, it's 85 patients, and the patients they chose that there were basically three different categories of patients that were in the study. There were patients that had been tried on bromocriptine and it didn't work. There were patients that were on bromocriptine but couldn't tolerate it, and then there were a handful that were untreated previously, and they were all given the cabergoline. Like I mentioned previously, all of them had tumor shrinkage, physical tumor shrinkage, and 94% of them were able to achieve pregnancy while on the cabergoline or post-cabergoline. And none of them had any fetal complications. The babies all were healthy. All babies in all three of these arms were born healthy with no issues. There was one stillbirth in the previously untreated, but otherwise the baby suffered no complications. Then to compare the difference between bromocriptine and cabergoline, there was a study, this was done a long time ago as well, this was done back in 1994, where they did a trial and they compared them specifically. This trial had a grand total of 223 patients, and they randomized them into cabergoline versus bromocriptine treatment. They used a lot smaller doses for the cabergoline. The cabergoline, it was done twice weekly, between 0.3 to 1 milligrams twice weekly. And in these, when they compared it to the bromocriptine, the cabergoline treatment group, when they looking at the table there, the table 2, clinical efficacy is were they able to become pregnant. So 74% of the patients in the cabergoline, overall 72% between the two groups, were able to become pregnant versus 52% of the bromocriptine group. And then biochemical efficacy is how much reduction/resolution of hyperprolactinemia they had. And 83% of the cabergoline group had complete success or resolution of hyperprolactinemia versus 58% in the bromocriptine group. And then looking at the graph on the right side there, the bromocriptine group just did not lower the prolactin as much as the cabergoline group did. And then in that same study, looking at the side effects, bromocriptine group had significantly more side effects than the cabergoline group, specifically more GI side effects, nausea and vomiting especially. And so, based on this, and this is just one of the studies that have looked into this, cabergoline is seemingly more well tolerated and more efficacious, which is why it was recommended. So this guideline, so not only do they look into cabergoline versus bromocriptine, but they also wanted to look at, so then what are the risks for the fetus? So that, that one study didn't show any real risk, but overall they looked at a lot of studies, cohort studies, but mostly case report and case series. That's the bulk of their data comes from those. Just there aren't that many studies on this. And overall, the rate of complications in patients on cabergoline did not differ from age-matched population in patients who were not on cabergoline. And so overall, it seems to be that cabergoline does not cause any issues pre-pregnancy. Most of these studies did not continue cabergoline through pregnancy. So this is mainly pre-pregnancy. Some of them did though, and I'll get into that in a little bit. So based on that, the recommendation is that you stop dopamine agonist therapy once you are pregnant. Despite that meta-analysis that I was just going over, very few studies looked at it continuing therapy through pregnancy. So the recommendation is that because we don't really have the data, you should stop it. Unless they do state the caveat is that if the tumor is close to the optic chiasm and it didn't really change while on therapy, you can make the argument that you can continue therapy through pregnancy to hopefully avoid it from growing anymore. Another important thing they mention is do not check prolactin levels during pregnancy. The prolactin levels, they may or may not increase, and it's not a reliable marker of tumor progression. That was the study they cite is this overall meta-analysis of studies of looking into patients who had prolactin levels checked, and really, they were all over the map. A lot of times they go up, but not always, and it was not a reliable marker. There's no reason to check it or follow it. The other thing that's likely a question that comes up is, when patients have prolactinoma, will I be able to breastfeed? That's understandably a concern and a question that patients will have. And they say that, prolactin level itself does not predict breastfeeding ability. And they base this on a study that was done in Sheehan syndrome patients or patients that had pituitary apoplexy. It was a total of 114 patients. And what they looked at was basically through their results, what they found is that even if patients had little to no prolactin release, a small subset of them were still able to breastfeed successfully. So the level of prolactin doesn't necessarily correlate with with your ability to breastfeed. You can, based on that study, there were patients that were able to breastfeed and they did not have high or normal levels of prolactin. They had low levels of prolactin. So it is possible. Obviously, the chance of it happening is lower, but it is possible. And for that reason, you can tell a patient that checking a prolactin level is not going to tell us whether you'll be able to breastfeed or not post-pregnancy. We don't know. It's just one of those things that we'll have to find out. Now, if a patient has a macroprolactinoma, they suggest that you should have regular monitoring of the tumor growth with visual field testing, visual acuity testing, and potentially MRI without gadolinium. And this was based on this paper that was published in 2019, mainly a review article. Essentially, they were looking at all the studies done on pituitary tumors and pregnancy. And based on that study, they noted that patients that had a macroprolactinoma, if it hadn't been treated prior to pregnancy, so if they still had a macroprolactinoma and had become pregnant, those patients had an 18.1% risk of symptomatic tumor growth during the pregnancy. It's quite significant. Almost a fifth of these patients had some sort of visual field deficit or severe headaches or some sort of symptomatic tumor growth. If that is to occur, if during pregnancy a patient were to have symptomatic tumor growth, they do suggest that you can restart medical therapy. And then last resort would be surgery. If they're on medical therapy, it's not helping at all, their vision is impaired, you can do surgery. But both of those are based on observational studies. They just have not been, large studies have not been done on that. So that's why it's more a suggestion and not necessarily a recommendation. And it's more a case-by-case basis. Then post-pregnancy, they recommend that you reevaluate the prolactin level. And that's because there was a study done, published back in 2014, where they looked at 73 patients that had hyperprolactinemia pre-pregnancy, and post-pregnancy, 40% of them had remission. So it is possible that the hyperprolactinemia improves or even resolves post-pregnancy just on its own. And so it's important that once the patient has given birth, that after pregnancy, you check the prolactin level. They don't say exactly when you should check the prolactin level, just at some point. Now, to compare it to the Endocrine Society guidelines here. So the guideline we have here is the diagnosis and treatment of hyperprolactinemia. It was published back in 2011, so quite a while ago, and it does include a section on management during pregnancy. A lot of the same things. They recommend that you treat before pregnancy, and then once pregnant, you discontinue medical therapy, and that's due to insufficient safety evidence. They also mention don't measure prolactin levels during pregnancy. They do visual field testing if the symptoms are present. They recommend that the MRI should only be done if you suspect tumor progression, and surgery is the last resort. So a lot of the same stuff. A little bit less in-depth, but a lot of the same stuff. There was one key difference, and the key difference was that the Endocrine Society guideline here, they recommended bromocriptine during pregnancy if there's symptomatic growth, whereas the European Society, the newer guideline, recommends cabergoline. And this is because back when that guideline was published in 2011, there was very limited data for either of these medications. But at the time, there was one study that had been done on bromocriptine. It had been used in 100 patients in one study. And in that study, there wasn't any increase in complications for the fetus. And so based on that, because they had this data for bromocriptine and really no data for cabergoline, or very limited data, the suggestion was that we should probably, if we have to, use bromocriptine. In the last decade, there's been newer studies, and largely they're just retrospective studies, but they have shown that cabergoline is equally safe in pregnancy, and like I went over previously, it seems to have greater efficacy and less side effects. So now, this newer guideline, they would rather recommend cabergoline. And this was, again, based on that kind of meta-analysis of looking at prolactinoma in pregnancy and all of the, looking through all of the studies. And you can see here, bromocriptine, there's a lot more patients that have been on bromocriptine and then had pregnancy. They have a total of 6,000 now, it looks like, versus cabergoline, they've got 789 total patients. And then at the very far end of this table, on the far right, that's normal pregnancy, meaning patients that were not on these medications. And so comparing either bromocriptine and cabergoline to patients not on either of these medications, complications, the risk of these complications did not really differ. No greater increase in abortions, ectopic pregnancies, and any malformations for the baby itself. Really, the risks of those did not differ from the quote unquote normal pregnancies, and therefore they're considered to be safe, relatively safe to use during pregnancy if you have to. Still, there isn't a huge amount of data to back it up, but if you have to, it seems to be safe to use. Now, Next is acromegaly. So in patients with acromegaly, pre-conception, the European Endocrine Society guideline recommends that pregnancy itself can worsen glucose tolerance and hypertension. And these are issues in patients who have acromegaly as well. So it is imperative that these are well controlled prior to pregnancy so as to better improve control during pregnancy. And you're starting off at a better place rather than starting off in a worse place. They also recommend that if it's a relatively new diagnosis, if acromegaly is a relatively new diagnosis, that you should just have surgical resection prior to pregnancy. If acromegaly itself is mild, and by mild they say no comorbid conditions, so no diabetes, no hypertension. Essentially, you just have an elevated IGF-1. Pregnancy is considered safe without intervention. You don't have to treat it with medication. You don't have to do surgical resection. The pregnancy is safe. Going into that, or kind of linked to that, is that once pregnant, estrogen can induce hepatic resistance, not just once pregnant, but once you are pregnant, estrogen level increases. And so that can induce greater hepatic resistance to growth hormone. That can lead to improvement in any symptoms that a patient may have from acromegaly during early pregnancy. And so, one, it can improve symptoms, and two, because of that, it's considered to be relatively safe to go ahead and become pregnant if your acromegaly is mild and you don't have any comorbid conditions. Now, in these patients, if surgery is contraindicated, they suggest treatment with a somatostatin analog, either lanreotide or octreotide, or you can use cabergoline until pregnant. Now, neither of those, the somatostatin analogs or the cabergoline, neither is approved by FDA to be used during the pregnancy, and there's really limited data of use during pregnancy for any of these medications, even before pregnancy. But there's no clear indication that treatment is harmful to the fetus. So, in the limited data that there is on patients that have used these medications before becoming pregnant, there's been no adverse effects. They don't make a recommendation for pasireotide, another somatostatin analog, because there just isn't any real data behind it in pregnancy. And pegvisomant, a growth hormone receptor antagonist, that one they say there's just no data for use during pregnancy. So they don't say anything about it. They say it can be a last resort, but it should be an absolute last resort because they have no data, so we don't know. They, like in prolactinoma, they do recommend that you stop medications once pregnancy is established. Like I mentioned, the medications show very limited data. They do seem to be safe, but since we just don't have that much data, it's considered safer to just stop the medications. If needed, if during pregnancy there's symptomatic tumor enlargement or symptomatic acromegaly, they suggest that you can use octreotide or lanreotide if needed. And again, like prolactin, or the non-functioning adenomas, if surgery is needed, you can consider it in the second trimester. Do not measure growth hormone or IGF-1 during pregnancy, another important point. So the placenta itself produces a variant, or its own sort of variant of growth hormone, which can cross-react with the growth hormone assay. And IGF-1 levels can vary in pregnancy and in patients with acromegaly. So this was a study published back in 2012 where they looked at patients who had become pregnant who had acromegaly, and as you see in that in the graph there, a good amount of them had stable / reduction of IGF-1 by up to 30%. A decent amount of them had an increase in IGF-1 greater than 30%. NR means they didn't check it. So a good amount just didn't get checked appropriately. But there's a lot of variation in they can go up or down. And so because of this, it's not helpful to measure growth hormone or IGF-1. And so there's no reason to do it during pregnancy. Then they mentioned that post-delivery, you should reassess disease activity because they do, based on some case reports and retrospective observational studies, they've noted that some patients do have rebound disease activity postpartum. And so you should postpartum repeat a IGF-1, see where their disease activity is at. They do also recommend that you should do a postpartum MRI. They don't really give any recommendation as to when you should do this, how long post-pregnancy or post-delivery, or any sort of timeline. It just kind of mentions it, that you should do it. So fortunately, I don't know if there was, again, that there aren't that many studies looking into patients who have acromegaly who have been through a pregnancy. So it probably is very limited data on this. So at some point post-delivery, they recommend that you do an MRI. So now looking into our Endocrine Society guidelines here, in 2014 is when they last published the guideline, and that includes a section on pregnancy. And a lot of the same stuff, that they do recommend discontinuing the medical therapy. That the difference here, they recommend discontinuing it 2 months before you even attempt to conceive. And then in that interim, in those months, that you use the short-acting octreotide. And that's because, again, of limited safety data, and they know that an octreotide is known to cross the placenta. So that's a difference there, that they recommend stopping well before you're even trying to conceive, versus the European guideline says you can continue it up until you become pregnant. They do state that you can consider using the medications during pregnancy if needed for symptomatic tumor growth, however. And similar to the other guideline, they recommend against using pegvisomant due to lack of data. The Pituitary Society also just looked to see if they had anything, because they did publish an update to acromegaly management, and more recently in 2020. However, there was nothing about pregnancy specifically in that guideline, so there's nothing there. So the most recent one we have here is from 2014. Now, so just the differences between the two. So the Endocrine Society here, they have recommended, like I mentioned, that you stop medications earlier, 2 months prior to attempting to conceive versus once you're pregnant. And that the difference here is that there's no specific pre or post-pregnancy recommendations, whereas the European guideline goes more into that, reassessing disease activity, getting an MRI post-delivery, etc. Just a little bit more in depth. Now, the last disease entity I'll be going over is Cushing's disease. So this one has the least data by far. And first and foremost, the first thing that they recommend is that you shouldn't become pregnant. And that's based on the fact that in the few patients, there's less than 300 total cases in the literature, as far as I could find, of patients that have active Cushing's disease that had become pregnant. And in those patients, and you can see in that table there, they had higher incidence of every complication. Fetal loss, growth restrictions, hypoglycemia in the fetus, neonatal infections, malformations, etc. I mean, absolutely every complication was significantly increased in patients that had Cushing's disease, even versus those that had cured disease. And so first, the number one recommendation they make is don't become pregnant, which I think is an important thing to note. I mean, I don't know if it's a common practice to kind of counsel on contraceptive use in patients that have Cushing's disease. When you see them in clinic, that may not be something that comes up always. But it is an important thing to mention, though it is more difficult for these patients to become pregnant. It can happen, so it is important that they are aware of that they are aware that if they were to become pregnant, that the rate of complications is significantly higher. And so, a good contraception plan should be in place, and we should make sure that that is something that is addressed. For for the patients that do become pregnant with Cushing's disease, they suggest that you should consider treating them during pregnancy. Again, data is very limited. We just don't have that many, a few hundred patients. No medication is approved for use in pregnancy. Some of the somatostatin analogs, pasireotide, they don't recommend that, nor do they recommend lisodrostat, which is the 11-beta hydroxylase inhibitor. And they don't recommend those because of side effects from those medications and just insufficient data. Mifepristone, which at higher doses is a glucocorticoid receptor antagonist, but it also is used for abortion, so it is contraindicated. Surgery should be considered first line for these patients. If a patient were to become pregnant, the first thing to consider would be surgery. And so that table down there, it's looking at patients who had no treatment versus medical treatment alone versus surgical treatment alone versus getting both. Again, very limited data. Looking at patients who had both medical and surgical treatment, there's only 10 of them in the literature. And this is from a paper that had looked at really, they had done kind of retrospective review of as many cases as they could find. And if you get both medical and surgical treatment, that's the best case scenario. And anything less than that is worse. Surgical treatment is a little bit better than medical treatment, and no treatment is quite bad, with up to 30% of patients having fetal loss. They also mentioned that you should consider anticoagulation with low molecular weight heparin, and that's because both Cushing's disease as well as pregnancy can increase thrombotic risk. And in Cushing specifically, the prophylactic anticoagulation has shown to reduce morbidity and mortality. There was a study done back in 2002 where they looked into this, and it has been shown to reduce it. And then if you throw on pregnancy on top of that, though there is no specific data for Cushing's disease and pregnancy and being on anticoagulation, it's more so hypothesizing, given that both of these things are increasing a risk. It's something to consider, that if a patient was to get pregnant, you should consider anticoagulation for them. Now, for the Endocrine Society here, they published a treatment guideline back in 2015. There's no specific pregnancy-directed guideline, and there's nothing specific in that guideline other than they mentioned that metyrapone, which is another 11-beta hydroxylase inhibitor, it has been used in pregnancy occasionally, and there are no apparent adverse effects. So it's something that can be considered, but really that's all that's mentioned in that guideline. Now, the Pituitary Society, they also very recently actually published a guideline in December, so just less than a month ago. And in that guideline, they do mention that both cabergoline and metyrapone have been used in pregnancy, and they can be used, but neither are approved and neither have any significant data behind them. Interestingly, they also mentioned that you can consider bilateral adrenalectomy in patients that desire pregnancy. That sounds like a pretty extreme measure in my mind in patients that have Cushing's, to just go ahead and do bilateral adrenalectomy. I think it's obviously a very much so a case-by-case basis. I would assume it's more so in patients who don't necessarily have Cushing's disease, but maybe Cushing's syndrome and no specific or no tumor that can be localized, or someone who is really wanting to become pregnant as soon as possible. And in those cases, then you can consider a bilateral adrenalectomy. Though I think the patients that would actually meet that criteria are probably pretty few. So the differences between the two, or between the three essentially, that the European guideline, they do mention, or they do suggest using anticoagulation, which we don't have in any of the guidelines here. Neither of them, none of these guidelines really mention any specific medications, or they don't recommend any specific medications. The Endocrine Society here, they do mention that metyrapone has been used, And like I mentioned, the Pituitary Society, they also mention Pityrapone. But none of these three guidelines recommend any of these medications, just because there is really very, very limited data on these patients. All right, and so just to kind of wrap things up, I'm going to go over some of the key points. So for patients that have a non-functioning adenoma, the key points to consider are that these patients, you should consider surgery pre-pregnancy if they have a macroadenoma, or if the adenoma is near the optic chiasm, or if there is a hormonal deficiency, as it potentially surgery can correct some of that and promote fertility. If there is concern for tumor progression during pregnancy, you can do an MRI without gadolinium, and surgery, if needed, is recommended in the second trimester. For prolactinomas, before pregnancy, treat with a dopamine agonist. Once the patient becomes pregnant, you stop the dopamine agonist therapy. You can consider using the dopamine agonist during pregnancy if there's evidence of tumor progression, but it's generally not recommended unless you have to. And like I mentioned, the newer studies point to cabergoline being the better medication over bromocriptine, being that it's better tolerated and seems to be more efficacious as well. For acromegaly, the recommendation is surgery prior to pregnancy if possible. If needed, you can use somatostatin analogs or cabergoline if surgery is contraindicated, and you should stop them once pregnant. If needed during pregnancy, you can consider using octreotide if there is symptomatic tumor growth. And then for Cushing's disease, the first recommendation is to not become pregnant. And if you are pregnant, then you can consider using Pityrapone or cabergoline during pregnancy, but both of those would be off-label. Pituitary surgery is the first-line treatment, and bilateral adrenalectomy can be considered. And there should be consideration given to using prophylactic anticoagulation in these patients, given the increased risk for thrombosis. And that is all I have.
Very nice talk, Irfaan. So if there's any questions, you can unmute or in the chat box. And while we're waiting for any other questions, so let me just ask the first question. A question that comes up a lot in clinic in women that have prolactinoma post-pregnancy and are breastfeeding. Are there any recommendations about how long to wait after a woman completes breastfeeding to check the prolactin levels? Because I assume, the guidelines talk about post-pregnancy, but obviously breastfeeding increases prolactin levels as well.
Yeah, so they didn't, as far as I could tell, there wasn't a specific, number given as to when you should or timeline given for when you should repeat that prolactin level if patients are breastfeeding. So no, I didn't see that anywhere.
Thanks. Looks like we have a question in the chat. So what is the risk for hypopituitarism if a patient has surgery for a macroadenoma prior to pregnancy?
So, the risk is definitely there. The actual percentage, I don't know off the top of my head. And I intentionally didn't go over hypopituitarism just because that's a whole topic in and of itself in pregnancy. So the risk is definitely there. But, that's more so a separate topic in that, if a patient needs treatment for the surgery for the macroadenoma, they should definitely get it. The risk of them developing hypopituitarism is there, and then that comes with its own set of guidelines and treatment recommendations.
Irfaan, this is Joe. Nice talk. I appreciated it. You talked about the high morbidity in patients with Cushing's disease. What's the morbidity of pregnancy in patients on steroids for inflammatory disease? And is it because it's not hydrocortisone that it's different, that it's not cortisol? You know, I know there are a lot of patients who've gotten pregnant on prednisone. So,
yeah, you know, I don't know. I haven't looked into that, so I would have no idea. That'd definitely be an interesting thing to look into, comparing those two. But yeah, I don't know.
Ty or Jay, do you know?
I would have to admit my ignorance. I would imagine that it's significantly dependent on steroid dose.
Yeah, I think it's the same issues that patients, fortunately, patients on pharmacological glucocorticoid therapy are less likely to get pregnant, but they may get pregnant. And that's a very, very good, that's a provocative question. And I don't know what the outcome data is in steroid treated patients. I'm sure they have, I mean, just intuitively, you would think they are much more likely to have obviously gestational diabetes, and you can just conjure up a lot of potential morbid conditions that would be increased during pregnancy in steroid treated patients. But I don't know. That's something I need to review. Does anyone else know? Boy, I haven't. That's a very, very good question, though. One comment, that was a very nice talk, Irfaan. I think one of the biggest challenges I have is in patients who have Cushing's, you know, in reproductive age group women who are interested in achieving a pregnancy. Obviously, the first line of treatment is pituitary surgery, of course, but many of them are already on oral contraceptives, and I always strongly recommend they stop them because of the, you know, increased thromboembolic risk, and use some other form of contraception other than birth control pills. And I always struggle about what they should use, whether they should have an IUD, you know, barium contraception, obviously abstinence or something. But I think it's very important that some treatment intervention, preferably obviously pituitary surgery, be recommended prior to any pregnancy. The challenge is in the patients who've already had pituitary surgery. Either they've recurred or it has failed, and then they want to have a pregnancy. That's the challenging group. And there's just no prospective studies, as you point out, Irfaan, that just no good studies about pharmacotherapy. As you point out, metyrapone seems to be at least the one that has the most reports of use, mostly because it's been around the longest. I mean, metyrapone was introduced in the world in 1959. I was alive, but I was in grade school, so it's a long time ago. It's been around. But you know, it's, you know, bilateral adrenalectomy sometimes is the only option in some of these young women who have failed pituitary surgery or recurred from it.
Great. Other questions?
That was a very nice talk. You did a really nice job with it and brought out all the great highlights that we needed to know. One of the questions I had for you when you were looking at the studies for the use of cabergoline in pregnant women, okay, and women that were pregnant and were on the cabergoline, did you come across any data where they actually looked at like heart valve issues in the babies that of those mothers? Because I haven't found any yet. Did